Peter, what do you see any difference between them that strikes you that worth calling out at this point, or are they all still too early to see?
I think it's too early to know. I think that the overall response rates in all of them are obviously quite high. Depth of response is quite good. Median duration of follow-up remains quite short, and it's important to recognize that these depth of response in a lot of these patients continues to deepen over the course of time. I have patients between 1 and 2 years who are finally getting into complete remission. So I think we have to wait, in order to see any meaningful differences between the products.
Natalie, what's your experience with?
No, I would agree with what Nooper and Pete have said. I think one issue that has come up in our experience is just that the manufacturing time can really be daunting for patients, so that doesn't sound like a long time, 3 or 4 weeks, but there is this issue of patients just sort of falling apart during that interim and that you are unable to get them to the transplant. And a lot of the trials are fairly restrictive in what you can give patients, unfortunately. So I'm not sure it really makes a big difference what you're trying to do in terms of this bridging. I sort of feel like we should try anything, but I think that's still a hurdle. And again, going back to other CD38 BCMA targeted therapies, that is a disadvantage, that you just cannot immediately give it to an ill patient.
Tom, where are we going to use these?
Great question. And we've been lucky at UCSF because we've had all the products in clinical trial. And I agree with everybody that there's no real, can't really tell a difference at the current time. We've been very excited over the overall response rate, but a couple limitations. One, patients have to come to the licensed cellular therapies place, like the transplant center. And that's going to be a problem for a lot of patients. And so this isn't going to be for everybody, unfortunately. I think it's probably going to be less than half of the people that are going to be referred for a CAR T-cell therapy because they have to come into the transplant center. And then, we're all excited about the response rate, but the disappointment is for the majority of people, they're relapsing, and relapses continue to occur 1 year down the road, 2 years down the road, 3 years down the road. That's a stark contrast to lymphoma, where if they're in remission for 6 months, they tend to be in remission then forever, which is troublesome. I wonder what the advisors think. For me, the problem is I think these guys are all going to need maintenance after the CAR, and we just haven't addressed that situation at the current time. I think they're going to need something else other than just a CAR.
Although in fairness to the products, these are the worst of the worst patients in terms of the number of prior therapies and what their natural history would be. And to me, at least, it's quite miraculous that some of these patients sort of pick up their bed and walk and have their first ever complete remission that lasts, even if it only lasts for a year, it's often way better than what the alternative was going to be. So, I
mean, I think one of the most exciting things that we're all going to be dealing with is what about retreating people with a different BCMA targeted therapy? So, can we use a drug conjugate after a CAR T, or can you use a BiTE before a CAR T? I mean, a lot of the trials are set up so answering those questions right now is quite limited, but I think we're all going to try that. And I think, there's pretty persuasive data that BCMA can be downregulated at the time of a CAR T relapse, but comes back very quickly, particularly in people who have quite proliferative myeloma.